I did want to do a little something different today. Outside of my usual thing, I do talk about my career and how much I believe in what I do and what I do in my career. And I did make a PowerPoint that really kind of talks a lot about my career and the things that I do. So you guys can't see it, but I did have this as a presentation recently. And I think it's super important to kind of just convey this to you because a lot of people that may view my channel might be able to watch this or at least understand it. When it comes to talking about your career, I think it's very important to understand kind of what you're doing, why you're doing it, and how much time you really believe that you can put into it. Okay. Like believing that you're going to be the best is probably one of the most important things because at the end of the day, these are about patients' lives, right? So if you make a decision and you make it wrong, you might make the wrong decision, man, and that patient dies. And that's super important to understand because a lot of time we overlook different things and we think, well, I'm good enough. Well, I'm good enough. And over time, that good enough really doesn't have a lot of ground to stand on because at the end of the day, you should be better and you should be striving to be better. Okay. So what we're going to do is we are going to talk about your congestive heart failure patients with underlying chronic kidney disease because a lot of them we do have, and we kind of do need to manage a little bit better and do better with them. And understanding that you can treat with a little bit more balls is important because we overlook that and we just really don't try to push towards good management because we're so scared and we let it for the inpatient providers. The issue with that is that some inpatient providers aren't the best at it, and also some outpatients aren't. Well, these patients, man, at the end of the day, stressing the heart out, that makes a huge difference in the long run. That's why they have problems, heart attacks, mortality, and things like that. All right. So, the first thing, that we can talk about is your definition. You can have ischemic heart disease, which is the leading cause of death and cause of CHF. It is a complex clinical syndrome. You do have your issues with ventricular filling or ejection of the blood, right? That's where you get your ejection fractions. Many etiologies, variable workups, extensive. Primary purpose is more stabilization in the hemodynamic status. That's where you have your water pills or your diuretics, your beta blockers, GDMT, whatever you want to go off of that, okay? So your left ventricular ejection, you do have different aspects. You do have heart failure with uh, reduced ejection fraction, which is less than 40%. You do have heart failure with mildly reduced ejection fraction, which is only 41 to 49%, but you do have evidence. So your cardiac biomarkers and elevated filling pressures. You do have preserved ejection fraction, which is greater than 50%, but still has evidence, a little bit of biomarkers and, elevated filling pressures. You do have improved ejection fraction where previously it was less than 40% and then it got better. So you do see that improvement, and they actually do classify that. So patients with greater than 50% ejection fraction are sometimes underdiagnosed due to the workup stopping because patients kind of aren't really showing significant signs of symptoms, and the provider's like, well, hey, it's better than 50%, so it's highly unlikely that's really going to do anything to you. When in reality, it really will mess you up in the future. All right. So you do have the different stages. It's kind of categorized out. It just kind of shows you charts. I mean, you have your increased BNP levels, which we'll address in the future. That kind of shows you where you start to have a little bit more symptomatic heart failure problems. Your exacerbations, needing water pill differences, changing the medications, or an inpatient stay. Where they need to be diuresed or water taken off. The definitions, they kind of go into different things. You know, you do have hemodynamic ways to measure. So people who are in the ICU, they do have Swan's gains. You have different catheters that go in there and they measure pulmonary hypertension, your atrial pressures, all kinds of things. Then you have your non-invasives like your echo, where they just take an ultrasound and go around. So also you can use your BNPs, which are just levels to show the stress on the atria and ventricles. It's a peptide. It's a biomarker. It's what they use. If you're greater than 1,000, you're probably in some trouble. If you're less than 1,000, then you still have a little bit of trouble. If you're less than 200, then you should be okay. And that's a big thing to understand is there's different types of diagnostics. Did they have a prior history of a heart attack? You have that decreased blood flow, that damage to the heart, which then causes heart failure because now that ventricle or atrial can't pump the same. Okay. So then you also have your pro-BNPs, which can be used. We use that with Entresto. It just is a different marker. Your pro-BNP is your precursor, and it really should only be seen with atrial and ventricle, where the regular BNP, you do have that probability of other parts of your body that can set it off, okay? And Entresto, for some reason, does affect it. So pro-BNP is usually utilized if they're on Entresto to get a better look at it so that you're not falsely elevated at 1,500 and really it's 3, 4, 500, 600, You do want to use the BNP as more of a confirmation versus rolling out. That's usually done in the emergency setting. And then in the ambulatory, the outside, it's a little bit less valuable per se. You do have x-rays, physical exams, look at their legs, check if they have big JVD, things like that, crackles in the lungs, what have you, okay? You do have the idea that chronic elevated troponin levels, so you'll have those elevated because of the fact that you always have stress on the heart. A little bit of stretching in that heart causes a little bit of damage, which then maybe even causes decreased blood flow. And then you get damage again. And then you have this troponin elevation, which is the cardiac enzymes always spilling out into the blood, and you can see it when you check. Your kidney function levels, BUN, it can be attributed to your increased heart failure mortality. Don't get hung up on that though, because some of them need significant diuresis, and there's compliance issues. Okay, your electrolytes, sodium chloride levels together. Usually, if it's a low sodium and low chloride, and they look like they're losing weight, or you look like you're diuresing them well, likely they're dry. Okay, that's what you want to look for, both of those together. Chest X-ray. Look for pulmonary congestion, EKGs. You have QT prolongation, left axis dilation, deviations, and left bundle branch blocks. Also, you can also do a heart catheterization. That's also another way to check too. So with CKD, you have different definitions. They really go off of your GFR, which is just your glomerular filtration rate. You do have your greater than 90 is normal, 60 to 89. You start kind of going into a little bit decreased. 45 to 59, you're mild to moderate. 30 to 44 is your moderate to severe. When you're at 15 to 29, you are severe. You do have some other problems and you want to investigate that. These can be changed also with your diuretics, your water pills, because they're kind of hard on the kidneys. Less than 15 is going to be your kidney failure. That's usually somebody who might be on dialysis. Okay. Around 15% of the population do have CKD, which is pretty common. A lot of time it comes from blood pressure management too. A lot of people don't take care of their blood pressures depending on your population, and they start to have problems. CKD, you can break it down. Pre-renal, think about your CHF and cirrhosis, constant decrease in your renal perfusion, ATN, which is renal loss over time. There's an estimate. Nephrology can do calculations and see kind of when you might need dialysis in the future. Intrinsic renal disease, so nephrosclerosis, just damage to blood vessels. Renal artery stenosis, same deal. So making the vessels small on the way to the kidneys decreases perfusion. You can actually see a lot of this too when they get hard. This is the sclerosis portion, so can cause ischemic nephropathy, things like that. Intrinsic glomerular disease, nephritic, abnormal urine micros. Nephrotic, you'll see more proteinuria, more than you'll see like white blood cells. Shows very few in that regard. Common causes, you do have your, honestly, your post-streptococcal. You're going to have your infective endocarditis, your shunt nephritis, lupuses, things like that. When you go into 2B, you have things such as polycystic kidney disease, which you may hear from people saying, "Oh, I have a lot of cysts on my kidneys." You have nephrocalcinosis, like hypercalcemia, high calcium levels can cause it. You also have post-renal, sometimes like prostate disease. Think about it as past the kidney. So retention, tumors, masses, whatever can cause a lot of that, okay? You do have toxin-induced CKDs such as vancomycin back in the day. Some people didn't check their labs. You do have medication-induced, really high supplements, really high water pills, hypertension medications that are renal specific. All that together can sometimes affect them. You do have uncontrolled hypertension, which over time, it just really exceeds the protective autoregulation. So the kidneys can't compensate, and the filtration barrier injuries, which then make it worse. I remember having somebody in the prison, 20 some years old, on dialysis just from blood pressure issues. It happens. You do have hypoxia induced proteinuria. Too much protein can cause destruction. It's toxic to the kidneys. So that's something to think about. Your inpatient management, your symptoms, you can have rapid AFib, so you're going to want to watch for that. A lot of time I tell people atrial fibrillation is not always something that just happens on its own. Sometimes, or almost always, there's a driver for it. Yeah, you're going to have those couple where the heart just is messed up, but a lot of time there's a driver. Infection, medication, drugs, or heart failure, things like that, that kind of affect it. Or, you can have your kidney disease, high potassium and things. You do have a cough. It's going to be due to the pulmonary congestion. You have edema, bilateral lower legs, tight abdomen. Hey, ask them, is your abdomen always as big? They'll tell you, no, it's not ever. It just feels really heavy, really taut, tight. Can't really breathe real well. Your EKG changes. You have left bundle branch blocks, which are seen more with reduced ejection fraction rather than the preserved, just because there's actual changes there. Your diagnostics, chest x-ray, left ventricular failure, you're going to have your fatigue, your dyspnea or exertion, orthopnea, lay down, you're getting short of breath, crackles in the lungs, murmurs, pulmonary edema, your right ventricular failure is going to show you a little bit of ankle swelling, some fatigue, a little bit of JVD, hepatomegaly, murmurs. Pleural effusions, you're going to have your cardiomegaly, curly B lines, upper lobe venous congestion. You will see there is a mnemonic. They do talk about, your A, B, C, D, E, alveolar edema, curly B lines, cardiomegaly, dilated upper lobes, and pleural effusions. And a lot of time on these patients, you can go either way. Your assessment versus, x-rays. You have your numbers, your other BNPs and things. BNP, pro-BNP, your CMPs, your creatinines, your LFTs. Look for vascular congestion causing it so bad to go up in the kidneys, you'll have a liver elevation. Or is it the liver elevation that causes that, which is, different relationships. EKG, your echoes, you're going to look for your enlarged ventricles, atrials, ejection fractions, things like that, because you're going to want to know, is there pressure deviances, pulmonary hypertension and things. You have tools, you have your Lasix and Bumex. Your Lasix has a roughly a 2-hour IV half-life, where Bumex is about an hour, hour and a half. You're going to want to check the creatinine and GFR levels. Check your sodium and chloride. Make sure they're hypervolemic. Make sure they're not hypovolemic, Make sure that you start a higher dose, 80 to 100 grams IV at one time. That's okay. My original doctor I worked with, man, I'm a independent nocturnist, intensivist in Maryland. They do had one that was he was a nephrologist intensivist, and he believed 80 to 100. And if you look up the literature, it's there. You want to have a urine output of 150 milliliters an hour. If your GFR is lower, sometimes you need higher diuretics because you need to get that filtration out of them. What's going to kill them more? The vascular congestion that will cause them short of breath, hypoxia, and stress on the heart and maybe die, or busting the kidneys up a little bit, maybe needing dialysis short term, can go home on better management therapy. Your Lasix drip, if you have an AKI, it's great to use. You can bolus with 20 to 40 IV and then initiate at a 0.1 milligrams per kilogram an hour. I think that's very important to remember, or 10 milligrams an hour. You don't really exceed 100 milligrams an hour. Try to, match dose or at least get higher on your daily dose of that drip than what they are taking at home. Don't give them the same medication they're taking at home. You do have periodic assessments, Q6-hour BMPs. You want to make sure that you are checking to make sure that their potassiums are always maintaining. On heavy diuretics, you're going to have these heavy potassium losses if you're using a loop. If you are maintaining with also some potassium sparing, yeah, you might have some, but you start cranking in Lasix strips, you're going to have a little bit of a problem, If they start to have a decreased output, look at their weight changes as well. Make sure that their weight isn't significantly low because maybe they just don't have it, which is where you're going to use your sodiums and chlorides together to see that kind of electrolyte imbalance, hydration status. You know, some patients might lose 15 pounds in 24 hours. Don't neglect the physical exam. They had crackles originally, now they don't. Probably getting better. They're seeing less distress. They're not seeming that bad. That's fine. Trending BNPs, they do talk about it. It shows worse mortality. I do believe that's probably because people aggressively treat it so hard. You get it down to 20 from 1,000. That's a lot. Probably a huge decrease in the volume of intravascular fluid, and maybe they just can't handle it. Maybe they're too old and they need to still have that volume status, at least somewhat. Maybe not all the way gone. Okay. You're going to have your BiPAP management. It is something good to use. I do use this in the clinical setting. It is non-pharmacological. It's an adjunct to your diuretic, decreased risk of kidney irritation. It increases your intrathoracic pressure. In turn, it does decrease your venous return and right ventricular preload. Changes your lung volumes, which alter your pulmonary total vascular resistance, and it's a determinant of your right ventricle afterload. You do have severe right heart failure with your liver congestion, so you don't want to use a BiPAP at that time, okay? Due to the left ventricle pre and afterload reduction, it equals a cardiac output decrease. So you're actually decreasing what that heart can pump out. When you plan for discharge, be mindful. If you're starting to level off your weights and your electrolytes, look at, is that dose available to go home with? Is there a way to send them home on something similar? If your sodium and chloride are good and their weights are stable and they're not orthostatically hypotensive, look at sending them home on the same dose or decrease it by like 25%, just something. But don't put them back on what they came in with, man. Be aggressive. It's okay. Check their labs, do the things you have to do, and understand the process and what you're looking for, and it'll do better. Discharge them home in confidence. If they have a little bit of a CKD, it's okay to be a little bit mildly higher as a creatinine and GFR. Maybe that's just what it is for them to have adequate diuresis. Because remember, they have two kidneys, but they only have one heart. You blow the heart out, they're going to die. But the two kidneys, we can try to mess with it, fix it, do whatever, do dialysis, but they will die without a heart, okay? And that's very important to understand that that's what you're trying to save is that heart from being stretched over and over and over again, causing chronic problems. Remember, Lasix IV to PO, 20 to 40, all right? So if they're on 80 BID, it's 160 PO BID. Twice a day has bad compliance. They're not going to want to take 160 milligrams, try to go home at night and sleep. Torsemide is a great drug. It's almost 1-to-1 from Lasix IV to torsemide PO. It's pretty similar. They say 10 to 20, but I believe it's closer to 1-to-1, but it depends. You may be at a loop ceiling. You want to make sure if that's the case, look at other medications. We always usually start loops. That's what we do. Kind of add in your potassium sparing, spironolactone. Work well if on a loop already. Can be used for ascites as well. It does have extravascular volume changes. And then your thiazides, your little baby hydrochlorothiazide. And then you have your chlorothalidones and your Zoroxolin. But remember, Zoroxolin should be used for basically rescue only in CKD and end-stage renals where you can still diurese somebody even being on dialysis, okay? Chlorothalidone's right in the middle, but you're going to want to watch your electrolytes. It's still a pretty harsh medication. Loop ceiling, your diabetic resistance where your failure to increase your sodium output and fluid output sufficiently to relieve the overload, edema, and congestion, regardless of the full dosing loop diuretic. You're just not getting that out of there on a dose that you think is what they should be on. Higher. Another definition is your failure of the oral furosemide to increase sodium excretion by at least 90 millimoles. That's over 3 days where a spot urine is obtained 1 to 2 hours after a loop. They just look at what your sodium content is. If it's less than 50, usually it's an inefficiency because you're not really getting that good diuretic flow to get it out, to bring the fluid out. So you're kind of just treating the same thing. You're not really making a difference. CKD stage 3 or 4, you can get up to 240 milligrams. This is where a lot of these doses increase. And end stage renal, you can be at 500 milligrams a day of furosemide. CKD, hypoalbuminuria, which causes a decrease of the excretion of the fluid. That's because furosemide actually works off of that albumin aspect. Decreased renal blood flow, they have stenosis, sclerosis, whatever. You decrease the blood flow, you bring the volume out, and all of a sudden it goes up. that is an issue. Uh, Also, it does decrease your diuretic delivery, so it may just not work as well. Studies that show an ACE inhibitor, it does increase the furosemide natriuresis modestly due to replacing the work of the sodium reabsorption with regard to decreasing renal vasoconstriction. You always see a little bit of low dose of those put on somebody. Sometimes, though, be careful. As you get farther on, you may need to discontinue it due to kidney irritation. When you send them home, remember Lasix can go up to 2,000 milligrams a day. That's legit. I've seen it in other countries, and it is legit. But you kind of decrease fluid in between HD treatments. All right. It's sometimes seen though that after a year, it may decrease the effects, which is what I mean, the loop ceiling. Half-life changes regarding liver disease, vascular congestion. Torsemide is heavily hepatic eliminated. So if your liver's bad, you take torsemide, which is a great diuretic. It's excreted more that way. Now your liver doesn't work. Now your half-life's longer, 6, 7, 8 hours. Just remember that when it comes to your dosing. Coumadin, binds to a similar protein, so basically need for increased warfarin doses relating to displacement of the warfarin with these medications. Digoxin, remember that you're going to have your furosemide loops. They can cause hypokalemia. That's super important to remember because if you pair it with your digoxin, you can get hypokalemia digoxin-induced lethal arrhythmia. And a lot of this is important because as you treat your patients, you kind of just want to have a general knowledge about what you're experiencing, like what you're expecting to come out. What type of diuresis are you expecting? Some patients you need to let a little wet. You need to have them a little wet in their veins. You need to have a little bit left in there because if you don't, a lot of the time you can't get them to maintain blood pressures, they're orthostatic hypotensive or what have you. That's an important thing because when you look at these patients, their compliance is always going to be number one. They don't want to pee all day, so look at your medications. Also, you don't know what they're eating at home. Maybe they're poor. They just don't have money to get good food. They're buying a lot of salty food, buying a lot of processed food. It's okay. But you need to tailor some of this to that. Hey, if you go out to a certain place to eat, take this medication today too. Keep them balanced as much as you can all the time. You know, when you look at these patients, it's super important because of what you're doing, why you're doing it. You're trying to make a difference in somebody's life because that's what needs to be done. You need to do better and save their life from, let's say, better than the next person who may have seen them. You want to be better every day. So understanding that you can be a little ballsy on these patients, be a little bit more diuretic happy on these patients, because remember, it is scary to not be able to breathe, but most people don't realize that their kidneys don't work. Okay. That's always something to remember. Their heart is whatever, it'll last. You have one and you only have two, you have two kidneys. You can fix certain stuff, but you can't fix a heart. So always trying to remember that no matter what, you push as hard as you can to be the best that you can. I do appreciate you guys listening to this presentation. I know you can't see it. I'll see if I can try to upload it, but I just thought it was semi-informative, just something a little bit different at what I usually post as well.